Hello, I'm Azim Latif from New York. Welcome to day 2 of TIO. After an incredible day yesterday of structural heart interventions filled with great presentations and live cases, we switch now on day 2 to coronary interventions. The program will be split into two. The first half will be concentrating on contemporary insights into intravascular imaging and physiology, and the second session will concentrate on mechanical circulatory support. As in typical TIO style, we'll have a few presentations, followed then by great live cases on the topic. And today we'll have live cases from Toulouse, New York, Leipzig, and Rotterdam. Our thanks to the faculty from yesterday for making yesterday such an incredible day. Here's what's coming up today.
Welcome, everybody. I'm really looking forward to this day at TIO, day 2. I have a great panel, illustrious panel in front of us. We have Joost Damon, Margaret McEntegart, David Hildick-Smith, and we also see Nicholas Van Meegen as well to join us to enjoy this discussion and didactics followed by discussions and then case presentations as well. I think we really want to encourage audience engagement, so please encourage to communicate via chatting. Also, we have a poll to start things off. So let's show the poll currently at this time about the use of invasive imaging in our center. Do you use invasive imaging sporadically in a quarter of cases, quarter to half of cases, or greater than half of your PCI cases? So we'll wait for those poll questions to come in, and I think we're going to start with the first talk by Joost Damon, who's going to talk a little bit about hyperemic and non-hyperemic physiology. What are the essentials that we really need to know? And we'll then have a discussion on that topic. So with that, Joost, take it away.
So thank you, AJ, for the kind introduction. So it's a pleasure for me to present to you today again at TIO 2021 on the essentials of hyperemic and non-hyperemic physiology. So there's obviously a lot to say about the essentials of physiology. And the resting gradient is far from enough, but unfortunately, it's all I have right now. That's what Andreas Grünzig already concluded in the early 70s when he already recognized the importance of intracoronary physiology. So let's wait a second for the slides to pop up. So to understand and to refresh your memory maybe a little bit, it's good to a little bit refresh your memory on the basic concepts of FFR, meaning that it's not resting flow, but maximum achievable flow, which determines the functional capacity, meaning the exercise tolerance of a patient, and at maximum vasodilation, corresponding with maximal hyperemia or with maximum exercise, blood flow to the myocardium is proportional to the myocardial perfusion pressure, which means it's the hyperemic distal coronary pressure. So that means, translated in clinical practical terms, an FFR of 0.6 would mean that due to this particular stenosis, the maximum achievable blood flow to the myocardium supplied by this artery is only 60% of what it would be if this coronary artery were completely normal. So that means, for the basic concept of FFR, we need to use pressure to get flow. Acknowledging the fact that the coronary pressure is simple to measure, but measuring flow is more challenging. And with the known physiological equation of P is Q times R, pressure only equals flow if the resistance is very low and constant. That means that, in practice, the basic concept of FFR implies that you need to use a hyperemic agent in order to reduce resistance and keep that as minimal and constant as possible. But the key question is, do we actually need hyperemia to minimize the resistance? And that brings me to the basic concept of IFR, which takes use of the basic concept of the fact that the coronary flow is 2 to 3 times higher during diastole versus systole. Meaning that if you look here in this difference plot between the complete cardiac cycle and the wave-free period, being the diastolic part of the cardiac cycle, mean flow is significantly higher in the diastolic period, pressure is somewhat lower, but the resistance, and this is important, is absolutely minimized and constant during the wave-free or diastolic period. So that is the basic concept of FFR, which only holds if the resistance at rest during the wave-free period, IFR period, is equal or means that the mean resistance during hyperemia over the whole cardiac cycle is identical, FFR. So in order to understand whether the resting wave-free resistance is actually identical to the resistance achieved by maximum hyperemia by a hyperemic agent, San et al. Did some work for the basic concept of IFR already 10 years ago, in which they demonstrated that this is actually the case. So this concept holds, so the mean resistance is identical during the wave-free period as during the full cycle with admission of a hyperemic agent. And the same counts for the coefficient of variation of resistance, which is identical between both the diastolic cycle of IFR and the full cycle of FFR. Meaning that the stability of resistance is similar over the wave-free period and during hyperemia, which means that the hyperemic agent is in theory not needed, which could imply that you could just as well switch to IFR, which makes your procedure 4.5 minutes shorter according to the defined flare trial. But it also implies that you need to use a patented algorithm of a single vendor. And that changed over the past years because of the fact that people started to wonder, what is the exact definition of this wave-free period, and can we make this perhaps more generic? And that is the work that Marcel Inetveer did. You all have seen this 4 years ago in Eindhoven, in which they looked at all kinds of different definitions of the diastolic cycle. So taking the mean pressure ratio during the full diastole, during the mid part of the diastole, during a specific part of the diastole. And independent of these individual definitions, the correlation to IFR was virtually 100%, with Spearman rows of almost 1. Meaning that it actually didn't matter what kind of definition of the diastolic period you chose. And that brings us to 2021, in which we have an armamentarium of indices that you can use in your daily practice for physiological lesion assessment. PDPA, perhaps not that used that much, but you have FFR, a full cycle ratio with a cutoff of 0.8. You have contrast FFR, recognizing the fact that also contrast works as a sort weak hyperemic agent. You can use that as well with a cutoff of 0.83 as shown in the contrast study of Niels Johnson. And then we have our resting indices like IFR, the known wave-free period ratio with a cutoff of 8.9, which, as we've just seen, can be generalized to a general DPR with a cutoff of 0.89 as well. And then there is even RFR, which is a similar resting ratio. However, it's slightly different than the IFR or DPR because RFR takes the full cycle. So it's a full cycle ratio that takes the point in between the systole and diastole in which the gradient is the highest. That indeed is typically during the resting period, the wave-free period, being the diastole, but we know that can also be in perhaps 10 to 20% of the cases during systole. So that means there could be a potential discrepancy. However, we looked into that, into our own data, 500 patients in which we computed both RFR and DPR, and also here we found a nearly perfect correlation extending the studies of Marcel Inetver and concluding the fact that it actually doesn't matter which of these resting indices you use, they are all virtually 100% identical, meaning that also the cutoff of these ratios would be 0.89. Then, that brings me back to some more physiological data on PET-CT. So here, Guus de Waard checked the diagnostic accuracy of both resting indices and FFR versus PET-CT and concluded again that you actually don't need hyperemic agents and a hyperemic ratio like FFR because the diagnostic accuracy of these resting indices, in this case IFR, was identical to FFR and just as good. Except for PDPA, which numerically was slightly less. However, if you look at the area under the curve, also that performed actually quite well as compared to PET-CT, which was considered as the gold standard of ischemia detection. So now that brings us back to clinical practice. You know, most of us typically measure multiple things. You measure a diastolic ratio and then decide, well, let's give some adenosine. We're still used to that. But that brings me to this saying that Stephen Ford presented in Canada last year, and I thought it would be nice to show it again, saying that it's possible to own too much. A man with one watch knows what time it is, but a man with two watches is never sure. And that brings me back to the contrast study in which Niels Johnson already demonstrated the excellent correlation between resting PDPA, contrast FFR, and IFR versus FFR. But it also demonstrates that in 20% of the cases, or 15 to 20%, you might find discrepancies. And that's what Christian Cook already acknowledged. If you measure FFR and IFR, you find discrepancies in around 11 to 17% of the cases, which was also confirmed in the Erasmus when we looked at 500 cases in which we measured FFR and DPR in the same vessel. Interestingly, the only independent predictor of discrepancies in our institution over 500 cases was measurement in the LAD. Remember that, I'll get back to that in a second. And remember the fact that we don't live in a binary world. And that is important because I think it's good to remember that the benefit of PCI is clearly exceptionally high in patients who present with very low FFR or IFR values. But the benefit of PCI also starts to decrease quickly once the FFR or IFR values start to approach the threshold, so the cutoff of 0.8 or 0.89, whereas doing PCI in lesions that are physiologically non-significant, PCI might, in theory, even be harmful. And that only confirmed the findings of the Justify PCI trial, which was published also 6 years ago, showing us that the hyperemic flow significantly increased once the FFR is below 0.7. But if the FFR is above 0.7, there was no change or no significant change in the hyperemic flow post-PCI. So I think that is important to keep in mind when you look at these gray zone thresholds. Are there then other reasons to opt for either a hyperemic or non-hyperemic ratio? There's one final thing I would like to mention, which appeared to be very clear in the Define Flare trial, and that is the fact that if you use IFR, the likelihood that you will perform a revascularization is statistically significantly less as compared to when using FFR. And that's interesting, although you could then argue, well, in theory, that shouldn't matter that much because if you use either of both indices, the outcome is identical. Yes, that's true for the full study results of both Define Flare and Sweetheart as shown here. But what is interesting, if you look at the event rates in deferred patients, so patients who are deferred based on an IFR above 0.9, they have numerically lower event rates as those who are deferred based on an FFR above 0.8. You might wonder, why is that the case? These findings are not statistically significant. Well, I'm just bringing this up as a potential item for discussion because there is some more data on the LAD, and that's here again. If you look at the difference in the event rates of the deferred lesions, that is completely due to the LAD lesions. So if you defer a LAD lesion based on IFR, the likelihood that it will be a future event is statistically significantly lower as compared to the same lesion that was deferred based on FFR in this trial, a finding that was not found in the non-LAD lesions. Final slide, we also looked at this in our own population, again, 500 patients. And what we found is that, and I think this might be one of the explanations of the discrepancy, the mean values of either DPR or FFR in the LAD are statistically lower as compared to the non-LADs. FFR, for instance, was on average 0.81 versus 0.88 in the non-LAD, which means also that the number of discrepancies between the DPR and the FFR was significantly higher in LAD lesions versus non-LAD lesions. So maybe an item to discuss, but I think this is something that perhaps is something we're not completely clear yet. But just to conclude, so I think there's little reason to stick to hyperemic indices. Specifically, measuring just to confirm might not help you because more extensive assessment will provide you with more discrepancies, which then make the decision even harder. I think it's good to remember that the increase in flow following a treatment of gray zone and intermediate lesions is only modest. And the difference in LAD versus non-LAD lesions, to my opinion, definitely deserves future studies. With that, I would like to conclude and thank you for your attention.
Thanks so much, Joost. That was a fantastic overview. I think really summarized the slides very, very nicely. Sometimes people get lost in the weeds, and this was a complex topic that you summarized very succinctly. Let's get straight to the clinical questions here, and maybe I'll start by asking Margaret, do you still consider hyperemia the gold standard for assessing coronary physiology, or do we now know enough about what Joost and others have shown that we can sort of assume that non-hyperemic indices have risen to that level?
So great talk, Joost. Thanks very much. So Ajay, I think the evidence as presented is very compelling for the non-hyperemic indices. In our institution, I think you know that we still use hyperemia, but that's largely driven by the fact we do a huge amount of microvascular research, and almost all the patients who get physiology done are in one of our studies. But I think now, I think the evidence is really moving towards, in terms of efficiency and everyday use of physiology, that the non-hyperemic parameters are really taking the floor. I think the LED data is really interesting. What we've found in one of the studies we did recently, Target FFR, was that not only is the physiology seemed to be very different in the LED than the other arteries, but also it's very difficult to optimize your post-PCI physiology in the LED compared to the circumflex on the right. I'd be interested to hear your thoughts about that.
Yeah, perhaps, David, we can ask you for lesion assessment of the epicardial stenosis, not so much the microvasculature. I mean, have you abandoned this, and is it just more confusion? I definitely see cases where interventionalists will start not believing the non-hyperemic result, then they give adenosine to try to understand it better, and then they box themselves into this corner, and oftentimes we just tell them, well, why don't you start at the beginning before you did anything? Why was the patient there in the first place? Make the decision. So, David, what do you think? You're very practical about these things. I can't hear him.
No, we can't hear him.
You may be on mute.
So sorry. Schoolboy error. Can you hear me now? Yeah.
Off of mute. Go ahead.
Sorry. So for me, the argument, what you presented is really fascinating. IFR versus FFR versus RFR, and scientifically really fascinating, and especially the data from the LAD. But, in practical terms, in a catheter lab, and this might be heresy to say it, but it sort of doesn't really matter, I think, generally speaking, which you use, so long as you're using one. I think we'll see in our poll, actually, in many labs, and ours is the same, there are constraints and reasons why people don't use the technology. So you might find, only 15% in the world of cases are actually being done with one of these indices. So to do one of the indices is really important, and it may not matter so much which. And absolutely, as AJ very rightly says, for me, you can get bogged down in the numbers and treat it as a binary outcome. And you very clearly said, no, don't do that. But people do tend to do that and say, oh, it's 0.84, I don't need to do something. Oh, it's 0.78, I do need to do something. But you've got to put it in the context of the patient. So does the patient clearly have angina or an angina equivalent? Are there other reasons why the FFR might not be a correct suggestion of what the coronary physiology actually is? You have to put all the various bits together, patient presentation, ECG, troponins, FFR, IFR, whatever. And so I think as long as you remember that and put that all together, you'll usually end up doing the right thing for the patient.
That's great. Nicholas, tell us, how do you do it in practice? How should somebody who doesn't do a lot of this, exactly to David's point, start incorporating it either regularly? Is it only post-PCI? Is it for lesion assessment pre-PCI? What would your advice be?
Yeah, well, I think it is an integrated approach, and there are not so many physicians who know the ins and outs of all these indices. I think even in our center, Joost by far is the master of coronary physiology, and the other physicians, we try to get familiar with one of the indices, and yeah, typically it still is FFR at this day and age, I think, in our center. But we do all the measurements. We measure the RFR, we do the IFR, and the PDPA. But I think practically I would rely on FFR when I'm in doubt of the patient's symptoms and complaints and there is an intermediate stenosis. On the other hand, if there is a very typical history of exercise-induced angina and I have a borderline significant stenosis and the FFR is 0.81 or the RFR is 0.89, I would treat the patient. And then a part of the discussion that we now were comparing all these indices, I think what we're going to talk later on today, imaging is also a part of the puzzle. So it is, for me, it's a more integrated approach. We have been studying the value of post-PCI FFR and RFR and PDPA, but Joost is going to come with those data later this year. It's the FFR React trial, so stay tuned for that later this year.
I think that's a fantastic discussion. We need to move on to the next presentation, but I would just summarize to say, use physiology, make sure you're using it for the right reasons, for the right patients. It's just an adjunctive tool to be able to use this. I think the discordance and then the post-PCI physiology are areas of certain interest, and we'll get more in that regard. Moving now on to imaging, and Margaret McEntagart is going to tell us about invasive imaging for decision-making during PCI, and that should allow us a nice bookend to what we're doing physiologically in the cath lab as well.
So how often, sorry, I'll just wait for the slides to catch up. So how often are we using invasive imaging during PCI for decision making? So this is data from about 2 million patients from the US Medicare database. And you can see that in approximately 6% of cases, IVUS was used. There was a very similar analysis done by Roxana Moran's group in the nationwide inpatient database, about 2.5 million patients, which again showed 67% of patients either had IVUS or OCT. And in these large data sets, there was a signal that the use of IVUS or OCT was associated with both improved long-term and short-term mortality. In the UK, looking at the BESIS database from 2018-2019, we were using imaging in approximately 10% of our PCI cases. So what is the evidence that should persuade us to use more imaging? So we have large observational data on the use of IVUS and comparing that to angiography to guide PCI from the ADAPT-DES sub-study. And this showed that the use of IVUS improved clinical outcomes in the long term out to 2 years compared to angiography-guided PCI. There's also a number of meta-analyses comparing IVUS-guided to angiography-guided PCI, and this is just one of the more recently published series. This was 8 randomized controlled trials, mostly apart from the IVUS XPL, quite small studies, and looking at different specific lesion subsets. This showed improved MACE and some of the composite elements of the MACE outcome with IVUS guidance versus angiography. And what about OCT? So we have some observational data that again shows improved clinical outcomes at long-term follow-up if you use OCT versus angiography only. And there, again, more recently was a very large meta-analysis looking at both IVUS and OCT, comparing them to angiography guidance and comparing them to each other. And what this showed that both IVUS and OCT were associated with better outcomes compared to angiography, but it showed no difference between the two modalities, which at the moment is kind of consensus expert opinion. And lastly, we have the large randomized ultimate trial, which published its 1-year outcome of target vessel failure, and then more recently this year has published its 3-year outcomes to show that in all comers having PCI, if you use IVUS, there's improved target vessel failure out to 3 years than if you use angiography only. And very importantly, what this also showed was that if you take the IVUS if you take the IVUS to use in your case, but you don't use it to drive towards optimized targets, then it makes no difference. But if you use the IVUS and you use kind of optimization protocols for a good stent outcome, this is where you have the most significant impact. So are there specific lesion morphologies where imaging is more important? So if we look at all complex lesions taken together, so if we look at left main bifurcations, CTOs, long lesions, and ACS lesions, this is a large meta-analysis study that grouped all these lesions together and compared them to non-complex lesions. We see there's an incremental benefit of IVUS over angiography in the more complex lesions, as you might expect. In a more recent single-centre observational data set with adjustment, they also found that if you use IVUS in complex lesions, this improves your outcomes compared to angiography only. If we look at the individual components of that complex kind of cohort of patients, if we start with left main, another large meta-analysis that showed the benefits of IVUS over angiography when treating the left main. And reassuringly, when we dig into the UK database, we see that even back in 2014, we were using imaging guidance, either IVUS or OCT, in 50% of our left main PCIs. And how did this correlate with outcomes? So we're able to show, when we compared outcomes in the IVUS-guided left mains versus the angiography-guided left mains, that we had a 34% reduction in 12-month mortality using propensity score matching in over 5,000 pairs. If we look at long lesions, we have the IVUS XPL 5-year outcome data now. So this was a randomized controlled trial comparing angiography guidance to IVUS guidance in long lesions over 28 millimeters in length, and the primary outcome was target vessel revascularization, target vessel MI, and cardiac death. And you can see out to 5 years, the benefits of using IVUS in long lesions is sustained. And again, importantly, just like in the ultimate trial, they showed that it's important not just to use imaging, but to use imaging to guide you towards optimizing your stent outcomes to actually get any benefit from it. So lastly, in CTO, There have been 2 small randomized controlled trials, 1 large observational study, and then this more kind of granular, smaller observational study looking at the benefits of using imaging in CTO PCI. In consistent CTO, IVUS was mandated at the index procedure. You can see that with long stent lengths, out to 80 to 90 millimeters in length, and over 50% of these stented segments being in the subintimal space, with IVUS guidance at the index procedure, we're able to achieve very good clinical outcomes at 12 months and also OCT outcomes when the patient's returned for angiography and OCT follow-up. So when you're using imaging before you stent, you're maybe going to use it to assess your lesion significance. As Just just really nicely illustrated, physiology is obviously the gold standard for making a decision about whether you treat a lesion, but there are occasionally circumstances where you might do this with imaging. We might discuss that. You're going to use it to look at your plaque distribution, particularly around bifurcations of the left main. Look at the plaque morphology. Is it lipidic, fibrotic, calcific? Once you've pre-treated your lesion, you're going to check that you've adequately prepared it before you stent it. So particularly in calcium, have you fractured or debulked it? You're going to use it to size your stent, choose your stent length, and avoid geographical miss. Post-PCI, we have optimization targets illustrated in this really nice picture from the EAPCI guidelines. So the most important thing you're going to look for is your MSA, because that's the strongest predictor of your long-term outcome from your stenting. So you're going to aim for an MSA of over 5 millimeters squared. You're going to also look at your stent expansion. Again, aiming for a stent expansion ideally of over 80%, with this correlating most closely with an FFR of over 0.9 post-PCI. And also look to see if you've got any edge dissections or whether you've got over 50% plaque burden at your stent edges, again associated with target vessel failure. If you're dealing with the left main, you're going to use the 5, 6, 7, 8 rule in patients who are of small caliber. And you're going to use the 6, 7, 10 rule for your MSA in larger Caucasian patients. So lastly, what future evidence is coming that's going to persuade us to use more imaging? So I'm just going to mention very quickly a few of the trials currently recruiting. So in the left main setting, there's Optimal. This is a RCT of 800 patients looking at IVUS versus angiography guidance in the left main. This trial was due to start at the start of the pandemic, but they've managed to get it up and running and have recruited the first 100 patients. So it's got a primary endpoint of 2-year all-cause death, stroke, MI, and repeat revascularization. Looking at all bifurcations, left main, and also other significant bifurcations is the October study, which is now being recruited for some time. So this is looking at OCT guidance versus angiography guidance in significant left mains, again with a 2-year composite endpoint. And lastly, we've got Illumian 4. This is looking at high-risk lesions. So what we discussed earlier on is this kind of composite of complex lesions, so ACS, long lesions, 2-stent bifurcations, calcium, CTOs, and ISR. And it's looking at a primary endpoint at 1 year of MSA and target vessel failure, and it's got a kind of dynamic recruitment of 2,500 to 3,500 patients. Thank you. Back to Ajay in the studio.
Thanks so much, Margaret. That was a fantastic overview of the existing data, some practical points for when to use it and how to use it, and then what to expect in the future. Maybe we'll start by asking the panel, and maybe we'll start with Joost. Tell us, do you feel like there's enough data right now where interventionists should be using imaging routinely in their clinical practice, or are there only selected subgroups, or do we need to wait for the future data?
Well, I'm honestly a great believer in intravascular imaging. I typically use it in over 50% of my cases, which also perhaps reflects a little bit the complexity of the cases we see. I am convinced by the body of evidence that is currently available specifically for IVUS, but I dare to say that could be directly translated to OCT as well. But the key thing here is that, there is still a need for a particular level of training. And I think that that accounts for the presentation of the great presentation of Margaret, showing us the data of Ultimate, that imaging works. It helps you to really decrease event rates, but only in case you use it properly. You need to use it properly to do pre-procedural lesion assessment, for instance, to look at the amount of calcium, do adequate lesion preparation, so to finally end up with an adequate stenting result with the criteria that Margaret nicely showed, because only then the benefit of IVUS or imaging is there. If you don't meet the optimal stenting criteria, there is no benefit of intravascular imaging. So yes, I'm convinced it works, it helps, and if you use it a lot, it doesn't add much time. But yeah, you need to spend time and effort in training and how to use it.
You know, I'm very curious to see the results of the poll, and we're still going to hold out, so please make sure you vote in on the poll, continue to chat as well about the use of imaging. But let me ask the panel, anyone want to raise their hand? Is anybody here on the panel, or will they publicly admit on the panel that they use imaging in less than 50% of their cases? Anybody? Anybody? No, I didn't think so. And it's interesting when you ask people at meetings, when we're going to actually have meetings again at some point, in the old days there'd be people raising their hands saying it's not needed. I see much less of that now. David, tell us a little bit, how do you use imaging in your practice? Are there practical applications, specific cases you use it, others you don't?
I think we tend to use it particularly for left main, obviously in clinical trials when it's mandated that it be used, and also in CTO. So I think it's a curious situation because the evidence has been accumulating value of imaging, especially in the active part. And so it's odd in a way that we don't use it more.
Yeah,
and I think is that the time? Is that the money? Is that the people aren't confident in interpreting the findings of the IVUS? Is it education and training? So there are many different factors, I think, that indicate why it is that still IVUS is only used in about 10% of cases generally.
Yeah, I think there are a lot of reasons why there's variable use. Nicholas, tell us, I mean, some of the interesting things, innovative things you can do with imaging maybe in the chip space. So things like, low contrast procedures guided by IVUS, perhaps even using saline for OCT. I mean, do you see those things as coming up more and more now? Have they changed what you do in the complex cases you see at Thorax Center?
I think for low contrast IVUS, there's no question. I'm a strong believer, and it makes total sense to implement it right away. I think for non-contrast OCT, we haven't been doing that in Erasmus at this point in time. I've heard about it, but we haven't implemented. And maybe you can enlighten me whether the results of an OCT with non-contrast, so with saline, is as good as contrast OCT. I'm not aware of that. I've never seen it, at least not in our practice.
Yeah, I think it's a challenge right now. There's definitely interest in doing it because of the ability to avoid contrast. Interestingly, in labs that use a lot of OCT, the additional contrast is actually very minimal, in some cases not even more than a conventional procedure, because you sort of streamline your workflow. But if you want to do it, there are concerns, small concerns about arrhythmia, and then the measurement is going to be a little different. It's going to be a little bit smaller than conventional OCT, so it's only a slight amount, but that's something to think about. You generally have to do it in vessels like the RCA where there are minimal branches. It's a much higher flow rate, or may have to do it through a guide extension. So in the left side. So you have to sort of study it a little bit more to be able to know what's going on. But these issue of using IVUS to do low contrast cases, I think most of the advanced operators sort of are familiar with it and do it now, but it's something that really can change people's practice in taking people to the lab with really elevated creatinines and poor renal function and offering them procedures that they might not have otherwise had. Any other final thoughts on imaging before we move on to the next talk?
Well, I want to have a small comment, Ajay. So in terms of this is exactly what you were mentioning in the beginning. So if you the more experience you get with OCT, the less contrast you will use in those procedures, and also the less contrast you will use during your OCT examination, because there are also multiple caveats and tips and tricks to improve the quality of your OCT study. So that is one. And I think also not every vessel is the same. So lesion complexity is one aspect of the story. Another one is, of course, that at least in my practice, the threshold to do advanced imaging is lower in the LAD and in the left main, because, you know, it's, if you compare to surgery, it is the LAD that hurts us. It's not the circumflex and it's not the RCA in principle.
I think those are great points. You know, with that, I think we'll move on to the next talk, which I'll be giving on imaging-derived physiology. All right, well, I have the task of trying to combine imaging and physiology together, and we'll be talking about what is called imaging-derived physiology. What is it, first of all, and is it the future of how we're going to practice in the cath lab? So what I'll speak briefly about are various modalities of deriving physiologic indices through the use of imaging. And so what we'll be talking about is not doing pressure wire analyses, but to actually look at physiology via the lens of either angiography, invasive imaging such as IVUS or OCT, and then briefly on CT, which many of you are familiar with. So to start off with, I think it's important to frame these things clinically. How could this possibly change my workflow, and do I really need it at all? And this is just a patient that was referred to me for a second opinion. The history is somewhat complex, but suffice it to say that the right coronary was occluded. There's this tight lesion in the proximal circumflex that was thought to be difficult to treat because of calcification there. And there's an intermediate lesion in the LAD, which you'll see in the next view. Patient has persistent symptoms besides optimal medical therapy and was referred for a second opinion. And I'll show you the angiogram of the left side because that's important when assessing this. Clearly, this circumflex is severe, but there's an intermediate lesion in the LAD, and this right has been occluded for some time and was not contributing to the change in the patient's symptoms. And so the clinical question when you see this patient in the outpatient setting with the CD of the prior angiogram is, what do you do? Do you just do PCI of the circumflex? Do you do PCI of the circumflex and the LAD? Or in some cases, do you send the patient for surgery? Because that had been asked of the referring physician, perhaps the patient ought to go to bypass surgery. And so I remember seeing this patient and thinking to myself, well, I just wish I had physiology of the LAD during that initial catheterization, because that would have made decision making at least easier. And so what we did in this case is we brought the patient to the cath lab, we did FFR of the LAD, we did a resting index, a hyperemic index, and we also used something called angio-FFR, which is an angiography-derived based way of determining what the physiology was. And you can see it was basically identical to the FFR, ended up treating the circumflex. The angiography-derived FFR of the circumflex was clearly significant, and the patient did very well with the resolution of symptoms. So the idea here, though, is that what if we had that imaging with the FFR derived from the imaging at the time of the consultation? Well, I could have told the patient then, we can treat the circumflex successfully, don't worry about cabbage, don't worry about the LAD, and it would have saved time during the procedure. So can we believe these results? Well, from the CathWorks study, and this is from the FAST FFR study, it does appear that angiography-derived FFR using this modality correlates quite well with invasively derived FFR. Now, there are caveats, there are exclusions to the trial, but this is important because it suggests that by not putting a wire down the artery, we could derive a surrogate of physiology. This is not the only system out there. There's several others. I'll also just show briefly on QFR, which is a system that basically takes the artery that you see the angiogram conventionally in a couple different views, 3D reconstructs the artery, derives a frame count of flow, and then is able to interpolate what the QFR would be, and this correlates with FFR. This is just data from Favor 2 China. There are other experiences using QFR as well that essentially show it correlates reasonably well with FFR, but what's important is that compared to QCA assessment of stenosis severity, this technology is far better than just using the QCA-based approach. And so by doing these types of algorithms, one can derive physiology and perhaps avoid having to put a pressure wire down in order to assess it. This is actually going to be studied in a large, almost 2,000 patient trial called the Favor 3 China trial. Here we go. I'm sorry, my slide wasn't advancing, which really looks at clinical outcomes of patients who are randomly assigned to using this based approach or using a conventional angiography-based approach to doing the PCI. And so we hopefully await the results of this trial in the next year, hopefully presented at TCT. Now, beyond using just the angiogram, there are other modalities that we use for imaging that can also be used to derive physiologic indices. So there's OFR, or OCT-based FFR. Traditionally, as on the left of the slide, you do a separate OCT, you would perhaps do a separate FFR, but what if you could combine the two, and when you did an OCT run, actually derive the FFR from the OCT itself? Sounds like a pipe dream. It's actually not. I've actually used this in a live case at the CIT meeting, and it's pretty impressive in terms of how it theoretically could work. Now, in terms of how it works, it uses a spatial resolution that's provided by an OCT image. There's a lot of information there with lumen characteristics, plaque morphology, which can also, by the way, impact physiology, and reconstructs that and derives through computational fluid dynamics a assessment of physiology. And the analysis time is approximately a minute with this system that's being studied in China. There's also other systems out there. This initial study has looked at what the specificity of it and the diagnostic capacity of it compared to QCA. It beats QCA, just like the data I showed with angio-derived FFR. This is also going to be studied in the Fusion trial, which is a trial being run by Abbott using that technology. This trial is ongoing right now, looking at simultaneous FFR and OCT to determine if OCT can be used to derive the FFR using similar types of algorithms. Now, beyond OCT, we could also do this with IVUS imaging, particularly high definition IVUS, which would give you more spatial resolution as well. Similar sort of concept, you do an IVUS run, you do an FFR run, but what if you could do them both at the same time? This same company is looking at this and basically able to derive 3D reconstructions and then using AI lumen contouring, able to generate a quasi-FFR value or a UFR value with an average analysis time of less than 2 minutes after you did the IVUS run itself. So these are things that are coming down the pipeline, and we'll likely be seeing more of them in the near future. When we look at the diagnostic performance of this, as shown in a study last year, once again, it beats QCA and appears to perform quite well as a whole. The last thing I'll talk about very briefly is CT-derived FFR. You have a huge data set of information when we do a CT scan, and by looking at computational fluid dynamics, one can derive FFR values. This has been shown to be correlated with invasively managed FFR. We now have several studies that have been looking at this in clinical practice to determine whether we can take a CTA, for instance, and then derive physiologic parameters to then determine if the patient needs to come to the cath lab or not. I think it's very important, and this is something we may talk about in the discussion, because CTA can often overcall stenoses. It's very great if there's no lesion whatsoever, but if they're intermediate stenoses, one often wants to know, and patients often want to know, if that's physiologically significant. And by combining this information up front, even before you get to the cath lab, we might be able to derive more information for patients. So just to summarize, why imaging derive physiology in the first place? Why can't we just use wires? Well, I think we know that physiology is important, and it gets back to the comments that were made before, that we need to do more of it. But because it's labor intensive, we don't do as much of it. So if you had another way of doing it that was essentially automated and taking evaluative information that you already had at hand, that would be great. And so basically you could do pre-PCI lesion assessment, strategy planning, you could use it intra-PCI and for optimization as well. And if we're going to use the imaging anyway, why can't we leverage those technologies to provide physiologic guidance and refinement to therefore help our patients? So with that, I'll conclude and then hopefully get to some discussion of this topic and then see the final results of the poll. All right, so maybe we'll start at the right of the pen. Nicholas, tell us a little bit, is this a pipe dream? Is it reality? Are you using any of these technologies right now? What do you think? Did I make a convincing argument or no?
Yes, you did. Yes, you did. And we've been talking about these concepts for quite some time now in the Thorax Center. But unfortunately, we haven't been using it and we haven't had too much exposure on it. What we do use, of course, is CT-derived FFR, and we had some brief interactions with those CT-derived and FFR. The bulk of our information and data that we are acquiring is angio-derived FFR. And again, I have to refer to Joost, who has built a whole research line based on this angio-derived FFR.
So maybe Joost, we'll go to you next. Some comments. Is it still research? Is it clinically prime time? I mean, I obviously, made the case for it, but there are logistical considerations to this. It's not as straightforward as I may have appeared to show it.
Well, yeah, I think I would like to make a few comments. First, I think you nicely demonstrated that it works. It correlates very well with FFR, and much better than does regular QCA. So I think that is already the key benefit. So with accuracy figures of 80–85%, I think it has the chance to be ready for prime time. With that argument that, again, we're not living in a binary world, and it's at the end not about whether the value is 0.79 or 81. It's about whether it's 75 or lower or above 85. So somewhere around that range. So I'm a very strong believer in using this, for instance, as a first-line screening agent. And whether that is CT or angio-derived FFR, I think to me that would be the same. And when in doubt, or when you're sure you want to treat, you use imaging on how to treat. But again, there's no outcome data yet, and I think that has to be awaited before these technologies will be adopted in the guidelines. You already alluded to Favor 3 China, that's on the way. There is Favor 3 EU ongoing, which now is 30% complete, enrollment complete. I spoke to Niels Holm this week. They expect to complete the trial end of the year, early next year. So that is data to be awaited. We are starting here the Fast 3 trial, in which we will randomize 2,200 patients to either VFFR guided stenting with the Pi Medical System versus FFR guided stenting. That trial is expected to start in the summer, so I think there's a lot to come, but in terms of clinical data, we're not there yet.
Got it. I mean, maybe, Margaret, putting this all together from the first talk to now, how do you see this playing out? I know you and your hospital are super involved in studying the microcirculature, and we haven't really talked about that, but maybe for epicardial stenoses, which is what most cardiologists deal with, at least in the cath lab, where do you see this fitting in, and maybe sort of summarize what we heard from the first talk to now? Where does this put us?
Yeah, so I think it's really exciting where things are heading, and I think it's all going to really facilitate efficient and kind of effective PCI for us going forward. I think my feeling from our service point of view is if we could really nail CT-FFR and also make it more cost effective, because that's our problem with that in the UK, then that would be a fantastic way to screen patients up front before even having to bring them to the cath lab. And then I think we have all these fantastic new parameters. So I think combining non-hyperemic parameters with imaging simultaneously for me is a very attractive prospect. Again, to make our procedures more efficient and also be more accurate and precise about exactly what we're going to do to try and drive towards better outcomes for the patients in the long run. So I think it's been a really informative session, and I think there's obviously a lot of interesting things coming on the horizon.
Yeah, thanks for that. And David, I'll give you the last word. You've seen the whole progression of this from, nothing at all to then arguments of FFR and then IFR and now CT-FFR. Have we made progress here, or is it just trying to find a home for new technologies? What's your summary of this?
No, I think we have made progress, but as you alluded right at the start, this is still technology which doesn't supersede everything we have ready. So it's additional to done. I think CT-FFR is particularly interesting because if you can
So
go
I think,
hard with information.
yeah, unfortunately, we still have an audio issue with you here, which is brutal because you can see he's expressive and he has words of wisdom, but we can't hear them. I guess my question there would be, maybe I'll ask Nicholas, what do you think? Is this progress or not?
I think it's an enormous progress, and I think it is becoming reality that we will no longer need these hyperemic wire-based indices. I think we're not that far from angio-derived coronary physiology assessment in practice. I think what Joost referred to as we do need to wait for some validation in larger randomized trials with clinical endpoints. I think that makes sense because we're all clinicians, but I think we're not that far anymore. And I think interventional cardiology and coronary PCIs is going to change dramatically once we can adopt this in our practice.
No, that's great. So let's now get to the poll, and then we can maybe have a brief few words on imaging. So let's see the results of the poll in terms of how frequently people are using imaging in their practice. So looks like sporadically still wins, but significant proportions that are using it over a quarter and even more than that. So I think that's pretty interesting, actually. Any comments? Let me ask Margaret, what are your thoughts on this? Are you surprised?
Yeah, I think that's really encouraging. Maybe it reflects the audience that we have on. It might be a little bit biased by that. But I have to say that as I get more experienced, I use imaging more and more and more. And if there was no cost constraint, and for me, it's not really any longer a time thing, because I think once you use it a lot, it's very quick if your lab's used to using it, so it's more a cost. If there was no cost constraint, I would use it in all my cases, absolutely, because I learn something from every time I get the catheter out, and I think it makes you a better operator. And I think I think we'll show as time progresses that it definitely improves patient outcomes. But I'm very encouraged to see that the proportions are going up from that 7 to 10% that the historical data is showing us.
Yeah, it's very different than what we would have seen maybe 5 years ago. And I almost get the feeling that it's like those polls we used to see of radial versus femoral, where you see it starting to tip, and maybe in 5 years it'll actually, really tip, and especially after the studies come out. Joost, what do you think? You're smiling.
Yeah, I'm smiling because I'm thinking about, who are these people that respond? And to me, it tells two things. First, these numbers are much higher than what we know is real world, right? So in real world, people use imaging on average in 10 to 15% of their cases. And here it appears that half of the people would use imaging in over 25% of the cases. So that tells me that there are a lot of people who believe in the evidence that is out there for imaging. They want to use it more than they perhaps currently do, but they still feel, let's say, drawbacks in using it. That might be cost, that might be experience, that might be availability of dedicated systems. So I think if we can improve there's a high likelihood that the percentage of cases with imaging will further increase in the coming years.
Yeah, I think that's entirely right. Certainly for our practice, we're using it in over 80% of cases. But I will say the referral films that we get in, more and more, you see an IVUS or an OCT run that's being done, and you never used to see that before. Similarly, people will do physiology of lesions that are, not in the culprit, and you see more of that. So I think there's growth, and the trial data will hopefully lead us to really show that as well. Any final comments, Nicholas or David? I don't know if the sound is fixed, but any thoughts?
Yeah, well, I think that we are a little bit over-reporting here. I think I agree with Jules that a lot of the physicians, they like the concept, they like the idea of talking about it, but the implementation in your practice is a different thing, and it requires quite some logistics, and there are some time and money constraints to it as well. But we are changing and we are tipping because the evidence is building. And at one point, there's no point anymore in denying it. I know now the majority of the compelling evidence comes from Asia. And then still the purists say, yeah, but maybe in the Western world it's a different scenario. Well, I don't believe so. I think imaging-guided PCI should be the now and the future.
It's a great way to summarize. I certainly couldn't have summarized it any more succinctly. So I think with that, we're going to move on to live cases. So this will be a great way of demonstrating what we've learned in this prior session. And we're going to be seeing live cases from St. Francis in New York City, good friends there, and the Clinique Pasteur Toulouse with Didier back on the screen as well. We're really looking forward to it.